All right, let's talk GYN nursing. I know it's a massive topic and it's so easy to get bogged down in all the details. So today we're going to cut right through all that noise. We're focusing on the absolute must-know red flags, the stuff that's guaranteed to show up on your exams and, even more importantly, the stuff that's going to keep your future patients safe. Let's jump in.
So this is the question. This is what needs to be running through your head as you study this stuff. We're not here to just memorize a bunch of random facts. We're learning how to spot danger. These red flags we're about to cover, they're the line between a routine visit and a life-threatening emergency. Getting these right is absolutely non-negotiable.
Okay, first up, let's tackle the palpable breast lump. This is always a high-anxiety situation for the patient, and for the nurse, it's a really high-stakes assessment. Being able to tell the difference between something that's likely benign and something that's potentially malignant, that's the critical first step.
Okay, look at this slide, because this is a classic exam question. They're going to give you a description and you have to know what it means. So let's lock this in. A benign lump, think of it like a little grape you can roll around under the skin. It's mobile, kind of rubbery, and has smooth edges. But the red flags for cancer, totally different. It feels hard, like a rock. And, this is key, it's fixed. It doesn't move. And here's the number one exam trap. It's usually painless. I'll say that again. Painless does not mean it's safe. In this case, it's actually a really concerning feature.
Now, it's not just about how the lump feels. You have to look for these visual cues because they scream advanced disease. See that peau d'orange, that orange peel texture on the skin? That's a huge red flag for lymphatic obstruction. A nipple that's suddenly pulling inward or retracted? That suggests a tumor is literally pulling on the tissue. These are the signs that mean you pick up the phone and report immediately. They need a workup, probably a biopsy, and they need it fast.
All right, let's switch gears to our next super high-yield area, abnormal uterine bleeding, or AUB. I want you to think of AUB as a critical distress signal from the body. It's a really common complaint, yeah, but hiding in there are some of the most serious GYN diagnoses. Your job is to be the detective and find the clues.
Listen. If you only burn one thing into your brain from this entire section, let it be this quote. This is a non-negotiable safety rule. You might be wondering why. Well, think about it. After menopause, the endometrium is supposed to be quiet, dormant. There's no hormonal cycle telling it to grow and shed. So if it's bleeding, even a little bit of spotting, something is wrong. We have to assume it's cancer until we can definitively prove it's not. This is a top-tier exam point and a massive safety priority.
So when a patient presents with AUB, how do you even begin to think through the cause? Well, you use a framework. First, you ask yourself, is it structural? Are things growing in there, like benign fibroids that can cause super heavy bleeding and anemia? Then you ask, is it hormonal? Like with PCOS, where a lack of ovulation leads to really irregular cycles. And finally, you always have to keep that third category in the back of your mind, malignancy. Structural, hormonal, malignant. That's your mental checklist for any AUB question.
So this next section is all about how pain, infertility, and infections are all tangled up together. They're a classic trio that you'll see on exams, and they love to try and confuse you with them. Let's break down how easily one can lead to the next.
Okay, exam trap alert. They love to put PCOS and endometriosis head-to-head on questions because, on the surface, they can both mess with periods and fertility, but they are totally different beasts. PCOS is fundamentally a metabolic problem. It's about insulin resistance and too many androgens, which is why you see symptoms like acne and hirsutism. Endometriosis, on the other hand, is an inflammatory nightmare. You have tissue growing where it shouldn't, causing crippling pain. So the nursing focus is different too. For PCOS, it's managing long-term health risks like diabetes. For endo, it's all about managing that pain. Do not get these two mixed up.
Look at this progression. This is a story you need to be able to tell your patients. It all starts so quietly, right? An untreated STI like chlamydia, which often has no symptoms. If it's not treated, that bacteria can travel up into the uterus and fallopian tubes, causing this massive infection called pelvic inflammatory disease, or PID. All that inflammation creates scar tissue, permanently blocking the tubes. And the result? The egg can't get through, leading to infertility. Or worse, an egg gets stuck in the tube, causing a life-threatening ectopic pregnancy. This is exactly why we are so aggressive about screening for and treating STIs, to stop this whole domino effect before it starts.
All right, we're in the home stretch. Let's wrap up with the biggest GYN cancers and a couple of high-alert meds that you absolutely, positively have to know for your exam and for safe practice.
I want you to just look at that number for a second. 99.7%. That is huge. Nearly every single case of cervical cancer is linked back to the human papilloma virus, or HPV. This is one of the clearest cause and effect links we have in all of cancer medicine. And you know what? That's actually great news, because it makes this cancer incredibly preventable.
And because we know exactly what causes it, that HPV virus, we have this amazing two-pronged defense strategy. Primary prevention is the HPV vaccine, Gardasil 9. It stops the infection from ever taking hold. It's literally a cancer prevention vaccine. Then we have secondary prevention, which is screening with Pap and HPV tests to catch any abnormal cells early, long before they ever become cancer. Your job as a nurse here is huge. Educating patients on how powerful both of these tools are is one of the most important things you can do.
Okay, stop and really focus on this one. Tamoxifen. It's a game changer for treating and preventing estrogen-positive breast cancer, but it comes with this really dangerous paradox. Here's what you have to understand. It blocks estrogen's effects in the breast tissue, which is great, but it acts like an estrogen stimulant in the uterus. And what does that do? It dramatically increases the risk of endometrial cancer. So the nursing takeaway is simple and critical. If your patient on tamoxifen reports any kind of abnormal bleeding or even spotting, that is a 5-alarm fire. They need an immediate workup. And our other big med alert is clomiphene. It's used to help with ovulation for patients struggling with infertility. The problem is, sometimes it can get the ovaries working in overdrive, and that can lead to ovarian hyperstimulation syndrome, or OHSS. This is not a wait-and-see situation, it's a true medical emergency. The ovaries get huge and fluid starts leaking into the abdomen, so your patient education has to be on point. They must know to report any severe abdominal pain, sudden and major bloating, or rapid weight gain immediately. That's a sign of a life-threatening complication.
Okay, deep breath. I know that was a ton of information. So if your brain feels a little full right now, let's just boil it all down. These 5 things, these are the non-negotiables, the exam passers, the lifesavers. 1. A hard, fixed, painless breast lump is a major cancer red flag. 2. Postmenopausal bleeding means you work them up for cancer, period. 3. Untreated STIs lead to PID and can cause permanent infertility. 4. The HPV vaccine is our best weapon against cervical cancer. And 5. Know your high-risk meds. Tamoxifen can cause uterine cancer, and clomiphene can cause OHSS. If you know these 5 things cold, you're on the right track.
And that brings us to the final question. Because at the end of the day, nursing isn't just about knowing facts from a textbook, right? It's about using that knowledge to make the right call right now. It's all about prioritization. On your exam and on the clinical floor, you'll constantly have to decide who needs you most urgently. So think through the red flags we just talked about and really ask yourself, who is in the most immediate danger? Answering that question correctly, well, that's the heart of being a safe, effective nurse.